Well, good day, everybody. This is Chris, the Ancient Scholar, and this is going to be a continuation of the videos that I've been filming on ventilator management, specifically talking about how to define a mode of ventilation, since that's a critical component to actually setting a ventilator up, making changes, and adapting to changes in patient physiology. So just to kind of combine multiple concepts together. A mode of ventilation, think of that as a kind of predetermined mechanism or method of patient-ventilator interaction. So mode is essentially how the patient and the ventilator interact, and it is a kind of there are a predetermined set of instructions, if you will, that you put into the ventilator, and a mode is that set of instructions that determines how the patient and the ventilator are going to interact with one another. And there are three major components to the mode. There are the control variables, right? So you have to choose when you set your mode what control variable, and typically in contemporary ventilators, that's either going to be volume or pressure. And remember, this is going to be volume control, pressure control, or volume cycled or pressure cycled. So essentially what you're doing is you are telling the ventilator what to use, what variable to use to cycle. And remember, cycle means to terminate inspiration and begin the expiratory phase of the mechanical breath. So what variable is used to cycle the ventilator? And generally that's going to be volume or pressure. The next step is the breathing sequence, right? And there are three major breathing sequences, and these are the major breathing patterns. There is CMV, which stands for controlled mechanical ventilation, and CMV is essentially, think of it as a breathing sequence where the ventilator is in complete control. And that is to say that there is little to no patient-ventilator interaction. In a true CMV situation, the ventilator will deliver a predetermined set of instructions based on the control variable, and it will do that in a way that is completely indifferent to whatever the patient is doing, all right? And so if you set, say, volume control ventilation, and you tell the ventilator to deliver a tidal volume of, say, 500 milliliters per breath, 10 breaths per minute, and you select CMV as your breathing sequence, that ventilator, in a true classic controlled mechanical ventilation sequence, will deliver 500 milliliter breaths, 10 breaths a minute, and that's it. No more, no less. It doesn't matter if the patient has an underlying respiratory pattern. The patient is attempting to interact with the ventilator is not able to interact beyond that sequence. Now there is another subsequence, if you will, that is technically or is often considered a part of CMV, called assist control. And in fact, some ventilators, when you select CMV, it is actually assist control. So in assist control, like CMV, since it is a kind of CMV, the ventilator is still in control, and like CMV, the patient is not able to take any spontaneous breaths. All right, so at the end of the day, the broadest definition for CMV is a breathing sequence where the patient is not allowed to take spontaneous breaths. In a true CMV, the patient is not able to trigger the ventilator. The ventilator is essentially delivering breaths, either volume control or pressure control, essentially kind of based on time, and the patient's not able to trigger it. In assist control, however, the patient can trigger the ventilator. Remember, triggering is what initiates the inspiratory phase. So the big difference is in assist control, When the ventilator senses the patient is triggering it, the ventilator will deliver a breath. It will not allow the patient to take their own breath, but the ventilator will sense the patient attempting to breathe and go, oh, patient wants to take a breath, I'm going to give the patient a breath. That's the big difference between a true CMV and an AAC, is that in CMV, the patient's not really triggering the ventilator and the ventilator is just delivering breaths. And in assist control, the patient can trigger the ventilator, but the ventilator will not allow the patient to take spontaneous breaths. Now, the next major breathing sequence is something called IMV, intermittent mandatory ventilation. And in IMV, the big difference is the ventilator will allow the patient to take spontaneous breaths, this IMV breathing sequence. So there is a mandatory ventilator setting, that's the MV, the mandatory ventilation. So you set your control variable, volume control or pressure control, and then you set some basic parameters. If you're, say, selecting volume control and you want that patient to get a 500 milliliter tidal volume and 10 breaths a minute, in IMV, the patient is going to get that breath, that 500 milliliter breath, 10 breaths a minute. However, if the patient's underlying breathing pattern exceeds the mandatory settings, the ventilator can sense that, and the ventilator will go, oh, okay, patient, you can go ahead and take additional breaths beyond what the mandatory settings are. There is a subcategory of IMV called SIMV. SIMV stands for synchronized intermittent mandatory ventilation. Again, it's still an IMV sequence. It's just a bit more specialized. And essentially what SIMV does is it's just a little slightly more intelligent form of IMV, where the ventilator is able to sense the patient's underlying respiratory pattern and then synchronize the mandatory breaths to prevent the ventilator from giving a breath at the same time the patient is taking a breath, right? So it attempts to synchronize the patient's breathing pattern with the mandatory settings of the ventilator. So that is the main difference between IMV and SIMV. Think of SIMV as just a specialized IMV, if you will. And then, of course, the third major sequence type of breathing pattern is CSV. And of course, that has to do mainly with spontaneous ventilation. And this is a sequence where the patient is spontaneously breathing the entire time. They are still receiving augmented breaths from the ventilator, and they're going to be getting pressure, flow, but the patient will be the one that is setting, rather independently, setting the underlying respiratory pattern. All right, and then finally you have what is called the scheme. And the scheme is what kind of sits on top of all of this, the control variable and the sequence. And the scheme is really all about all of the targeting variables that you can set. And so with the scheme, you set targets. And so the operator, that's the provider, is putting inputs in, and then the ventilator is delivering outputs that then sits on top. So this is your foundation, your control variable and your sequence, and then the scheme sits on top of that to produce the overall mode. And there are I would say at least 7, maybe more, depending on who you talk to, different schemes out there. Here are a few examples of schemes, such as the set point. This is probably the easiest targeting scheme to think about. And a set point scheme is where the operator, the provider, sets all parameters of volume and flow if the patient's in volume control ventilation, or the pressure waveform if the patient is in pressure control ventilation. All right, so this is probably the easiest to understand. So if you say put somebody in volume control, SIMV is the sequence, and set point is the scheme, that means that since a patient's in volume control, the ventilator, you are telling the ventilator to control volume and flow, and there's no wiggle room. It's set, and that is what's going to happen. Whatever the volume is that you set, whatever the flow is that you set, the ventilator is going to deliver that consistent with whatever control variable and sequence you set in, right? There's no wiggle room. The ventilator is not able to make any decisions, if you will, beyond those parameters. And then there are more complicated schemes like dual schemes, where the ventilator is actually able to change between volume and pressure control, and so it can kind of hybridize volume and pressure during a single inspiration, right? And so that is a dual scheme. And then there's something called optimal, and I wanted to mention optimal because this is a scheme that the Hamilton T1 ventilator uses. And in the optimal scheme, the ventilator automatically adjusts targets of the ventilatory pattern to optimize some performance characteristic of what's going on with the patient, things like work of breathing, for example, and lung mechanics. And there is a scheme called adaptive support ventilation, which the Hamilton T1 ventilator has, the ASV, right? And then there are other schemes like servo and intelligent that may also use a variety of different algorithms and machine learning programs that are built into the machine. And a lot of these individual schemes, this is where the naming nomenclature can get really complicated. And this is where a lot of the special secret sauce of ventilator manufacturers comes into play. You know, a lot of the NAVA, neurally augmented ventilatory assist, and VC plus, and ASV, and some of these exotic sounding things. Really what they're talking about is it is a company that has developed a scheme of ventilatory support that is focusing on certain set targets. Now remember, at the end of the day, you still have to have some control variable, and in some cases, if you have a dual scheme, the control variables can switch between volume and pressure. You have a breathing pattern sequence, and then on top of that, you put your scheme, and then at the end of the day, that gives you your overall mode. So for example, if I choose volume control ventilation, volume is my control variable that I use for cycling, and then I'm going to select CMV, control mechanical ventilation. Okay, so I know that that is, and let's just go with true CMV, not assist control, but just true bare bones CMV. That is a set tidal volume at a set respiratory rate. The ventilator is going to deliver that. It's not going to do anything else. And then my scheme is set point, where I set specific parameters, right? So there is a specific tidal volume because I'm in volume control, and there is a specific flow rate, you know, say 60 liters per minute, and that's going to give me a set I time, and a set I to E ratio, and an E time, and that is what the patient's going to get. And then that gives me an overall mode of volume control ventilation, CMV sequence, set point scheme, and that gives me a rather complete definition or understanding of what the patient-ventilator interaction is going to look like when I use this specific mode of ventilation. So this would be something like a really basic transport ventilator, you know, like an AutoVent 2000, or even an anesthesia machine. When somebody has surgery and they're under surgical anesthesia, and they just, the patient is completely unresponsive. There's no underlying respiratory pattern. And so the amount of interactivity doesn't really matter because you have a completely unresponsive patient. They're paralyzed. They're not breathing on their own. There's no underlying respiratory pattern. Then it would make sense to place a patient into a CMV sequence where the ventilator is giving a very specific set of instructions that it does not deviate from. And so this would be, probably your most basic form, mode of ventilation that you're going to see on your real basic transport ventilators, where you have, tidal volume, a respiratory rate, and that's all the patient gets. This is what that type of mode would look like: volume control ventilation, CMV sequence, and set point scheme. So hopefully this makes sense, how we can put these three concepts together: control variables, breathing sequence, scheme, to arrive at our ultimate mode. So hopefully this makes sense. And then what I'm going to do is try to take this intuition and use it to talk about the Hamilton T1 ventilator. And the Hamilton T1 ventilator, it's a little tricky to really understand fully what's going on, but we'll try to make some basic sense of it. All right, everyone, hopefully you enjoyed this video, and we'll see you in the next one.